What I wanted to do was go through the survey that you all completed over the last few weeks based on your readings of the U.S. Task Force article, as well as the guideline, as well as the 2 accompanying editorials that we provided you. So we had 88 people who responded at the time we put the slides together on Thursday morning. I encourage, well, it's too late now. You can't really do it now. So we had some questions about career interest. And so please indicate your career interest to the following specialties. And you can see this. It's kind of hard to read here. A lot of others, a lot of primary care, a lot of subspecialty internal medicine, anesthesia, some surgery as well. So the first question was a 55-year-old white man in primary care clinic for a general exam. He's not seen a physician in 10 years. He said no complaints or problems, no risk factors for prostate cancer, no personal family history of prostate cancer. Would you recommend obtaining the PSA test for screening for him? And so yes, we had about 1.2%. No, looked like there's about 40%, and discuss pros and cons about 60%. Next question, you see a 55-year-old African-American man in primary care clinic for a general exam. Again, hasn't seen a physician in 10 years. No complaints or problems. Has a younger brother who was recently diagnosed with prostate cancer at age 52. Would you recommend the PSA test for screening for him? Yes, 45%. No, 3%, and discuss pros and cons, 50%. This is Dr. Leslie from the Department of Surgery, Division of Urology, who is here as well to take the con position for PSA testing. Next question you had was in terms of a health fair. Would you want to include the PSA test in the options for blood work for the health fair? Again, the patients would not, or the customers or patients would not be seeing a physician on the day, and overwhelmingly no, did not recommend including it in that stance. You see a 55-year-old man in clinic who's requesting a PSA test. He's willing to pay for it himself if his insurance does not cover. And again, 80% would recommend doing the test, 20% against. And will you recommend the PSA test for prostate cancer screening in your clinical practice? Yes, 40%, no, 60%. And then there's some comments. With that, that's how you responded to, no, the comments were fine. There's nothing wrong with the comments. It's just the text was too small. So I'd like to start out with Dr. Silverstein presenting his argument, and then followed by Dr. Leslie.
Well, I first want to, thanks for inviting me here, but also want to just make a comment about screening, not just PSA screening. When you think about any screening test, what you're thinking about is getting a cancer at periodic intervals. So generally, the cancers that are going to be around at the periodic intervals are going to be the slow-growing cancers. The cancers that come in between screening are going to be the fast-growing cancers. So inherently, in every screening test that we do that comes in periodic interval, we're screening the wrong cancer. You want to get the fast-growing cancers, but if you wait every year or 2 years when you screen, the slow-growing cancers are going to still be there. So we're going to talk about why we should not do PSA screening. But you can actually make similar arguments, not quite as profound, but there's a reanalysis of the breast cancer data, and a lot of the breast cancer data also suggests that they're not as useful as before. An interesting thing about breast cancer is they did a study, and they looked at countries that had breast cancer screening and countries that did not have breast cancer screening. And even in the countries that did not have breast cancer screening, they had improved survival in breast cancer. And the theory there is that improved treatment helped breast cancer, not just the screening. Okay. So again, screening detects the slow-growing cancers. The fast-growing cancers are going to kill you. You do not detect. It is estimated, let's say for prostate cancer, that over 50% of the cancers that you screen and find would never have killed the patients. Probably 30% of patients who have breast cancer screening, the cancers that they detect would never kill them. Even in lung cancer, you can do screening for lung cancer and find lung cancers, never screen them, never will kill them. So the theory that you just have cancer and you're going to die from the cancer when you get it is not true. I'll show you later, in a most recent study, that if you find a PSA-detected cancer and you say, I'm not going to have surgery, only 8% of those patients die from the prostate cancer. Here's somebody, they diagnose with prostate cancer, and you say, you don't do anything, or at least right away. Only 8% die. So the vast majority of men who are diagnosed with prostate cancer do not die from the prostate cancer. And the vast majority of men who are diagnosed with prostate cancer suffer side effects of treatments. So what are the side effects of treatment? So if you have treatment, you get a biopsy, you get hospitalized with a biopsy, you have surgery, 1% of people die, you have radiation or surgery, you get impotent, you can have bladder incontinence, bowel incontinence. So therapy is not benign. So when you look at screening tests, you got to weigh the risk and the benefits. So you got to add up what is the death rate from screening. Okay? For example, in breast cancer, when you do frequent mammograms, that's radiation therapy. When you give radiation every year to a woman, you're going to increase the risk of developing cancer because you're giving mammograms, which are radiation. So there's a risk to these therapies. Okay, so again, back to mammograms, age 40 to 50 was not shown to be useful. There was incredible yelling and screaming, and Congress changed that. Okay, so not because of scientific evidence, but yelling and screaming, the government now says you should be screened. Okay. Interesting, in Obamacare, one of the advantages of Obamacare is there is free screening. So Obamacare says screening is useful, and we'll give it free to everybody. So if prostate, breast, colonoscopies are now free under Obamacare, or will be. Okay. So a couple years ago, the U.S. Preventive Task Force says that screening was harmful in men age 75. So one Warren Buffett, who happens to be 80 years old, presumably was screened for his PSA and presumably is getting radiation therapy for his prostate cancer. And many of us, including myself, think that he got inferior care, that giving Warren Buffett, an asymptomatic 80-year-old, PSA screening and then treating him, he's more likely to have harm from his treatment than benefit. The chance of him dying from an asymptomatic prostate cancer is very low. Again, back to breast cancer, much of the reduction of breast cancer mortality may be due to treatment. So many women write in these women's magazines, I got breast cancer detected on mammogram and I was saved, okay? In actuality, only 10 to 13% of those women were saved. So 70 or 80% of the women who got their breast cancer detected were not saved. So just because you have a cancer detected does not mean you're saved. Okay? The other argument in mammograms is this. They say, here's a woman who was age 42 had breast cancer. Therefore, doing mammograms at age 42 is helpful. That is not scientific evidence. Just because some women age 42 get breast cancer doesn't mean that screening is useful. You have to show that screening reduces the risk. Back to breast cancer. Younger women have dense breasts. Dense breasts are difficult to examine by mammograms. So mammograms are very poor or relatively poor tests in young women. Older women have more breast cancer. So when we screen age 40 to 49, their chance of getting breast cancer is low, and the sensitivity and specificity of the mammogram is low, so it's not a particularly good test for 40 to 49-year-olds, both because the incidence of breast cancer is low and also the mammogram is harder to read. It is much easier to read a mammogram in an old lady with fatty breasts. Okay, so of the men, 44 million men over the age of 50, majority have had PSA. So 33 million men have had a PSA test. Okay? So who's had it? And all these people claim that they were saved. Joe Torre, baseball catcher and a manager of the Yankees and the Dodgers, he was saved. Michael Milliken, a financier and kind of a crook, went to jail, but now he's out of jail and he is promoting prostate cancer screening. Rudolph Giuliani, and he was the mayor of New York, 9/11, and he spent months agonizing on which treatment he would get. Okay. So, in the last 10 years, 1 million men had surgery or radiation because of screening. So we think 5,000 of those men have died from surgery. Okay? 10 to 70,000 men have had serious complications. 200,000 to 300,000 men have had impotence, bowel, or bladder incontinence. So there's significant side effects to this. So you have to weigh the side effects to the benefit. Okay? Autopsy studies. If you do an autopsy in men over the age of 85, 75% have prostate cancer. So if you look, you'll find it. That doesn't mean they're going to die of prostate cancer. That means they haven't. 30% of men aged 40 to 60. So it's very difficult for us to tell who's going to die from the prostate cancer, and it's a huge prevalence of prostate cancer. 16% of men have a risk of developing diagnosed with prostate cancer in their life, but only 3% risk of dying. So there's so many more men who diagnosed with prostate cancer than die from it. The majority of men who die from prostate cancer, the median age of death is 80. So you're not going to die from prostate cancer for 10 or 15 years after you get it. The 5-year survival of prostate cancer is 99 to 100%. So almost everybody for the first 5 years lives. Okay? The 5-year survival is 99% for prostate cancer. Now, many men are treated with anti-hormone therapy for early prostate cancer. That's not approved, it's not recommended, but it's frequently done. You can give GnRH analogs like Lupron, and that reduces, basically is a medical castration. It reduces your PSA level, but has never been shown to improve the survival in early prostate cancer, and there's significant side effects from that. So even if you have men who have normal prostate levels, and you biopsy them, 25% of men with normal PSAs have prostate cancer. So what number do you pick for PSA? If you pick 0, still 25% of men with normal PSAs have prostate cancer. So there's really no good cutoff to say which level you're going to get prostate cancer. No matter what level PSA you find, you're going to find lots of men that have prostate cancer. So Dr. Leslie will go in great detail this, but overall, there is no, in the meta-analysis, no clear reduction of prostate cancer deaths in PSA screen studies. And that's really the basis of the U.S. task force. There was no improvement in survival. So there are 2 major studies. One study, the European study, 182,000 men aged 50 to 74, and they were randomized to PSA screening yearly or usual care. Okay? But there was a 0.6% reduction in deaths, but that was not statistically significant. And they figured that if you screened 1,400 men, you treated 48, and then 0.07% reduction in cancer deaths. So all the men who were screened had some issues, but clearly those 48 men who were treated, those 48 men who were treated have a risk of impotence, bladder incontinence, and bowel incontinence, and surgical complications. The U.S. trial, PLCO, 11-year follow-up, they actually had a slight increased risk of the prostate cancer deaths. They randomized again, similarly 76,000 men. And they used a PSA cutoff of over 4. And 90% of men who get prostate cancer receive treatment. And let me emphasize that. So people say, oh, let's get the test back and we'll decide. Well, almost everybody, if you tell them they have prostate cancer, they take treatment. So if you know it, you do the test, they're going to have treatment. Almost nobody, 90% of people, once they have PSA-detected prostate cancer, get treatment. So the idea of, oh, we'll just do the test and then decide not to treatment, that doesn't happen. Okay? Now, there are issues in the control arm. So 50% of men in the control arm had 1 PSA. But these are the biggest studies we have. What about the harm? So after you had 4 PSA tests, you have a 5.5% risk of false positives, and you have a negative biopsies. So what's the harm of biopsy? No big deal. Well, 0.5% of men after biopsy get hospitalized, hematospermia 50%, and hematuria 22%. So biopsies have some risk. So they estimate 46 to 67% of prostate cancer don't benefit from treatment. Unfortunately, we do not have a very good tool to figure out who's going to benefit from treatment, who's not. Prostate cancer is the 2nd leading cause of death in the United States from cancer. Another estimate, to save one life by PSA screening costs $5.2 million. And that's felt to be cost ineffective when you compare it to other things. Compared to vaccines or whatever else, $5.2 million to save one life. And many patients will be harmed. Okay, here's a recent study. This is done in the VA. This is the only study in PSA screening error. There are other studies that did prostate cancer and randomized it observation or surgery, but those are people who had bigger prostate cancers. These are people at the VA who had a PSA like we would do today. They had 730 men. Half of them got nothing, observation, and half of them got surgery. You would think, that people who had surgery would live longer. No difference in survival, no difference even in prostate-specific survival. So you found these veterans, and you operated on them. You didn't help them one iota. Okay? Interestingly, if you had a PSA-detected cancer, you only have an 8% risk of dying from prostate cancer. 92% of the men who have prostate cancer will die of something else. Okay? And now, you could look at or subset analysis, and maybe the people who had PSA greater than 10, maybe they did have some benefit. I'm sure Dr. Leslie will not agree with me.
Dr. Silverstein is always a tough act to follow. Doesn't know is I got a few ringers in my slide set. First, I want to thank you for not only having me here, but also for picking one of my favorite topics, PSA screening, as a topic for this evidence-based medicine review. Not only do you get the benefit of an intensive review of a hot and important topic, but also we get to do this talk more than once, so I get to be a little better at it. My goal is to not only talk about PSA screening, I'm looking at it this way. If you're a true believer and you believe PSA screening is going to save lives, and Dr. Silverstein's a true believer, as you heard, that it doesn't, my goal is to convince you that my way is correct, because then you'll go out and save a life. So this is more than just a fleeting exercise for me. This is a life and death discussion. So there's no hold bars till the end of the panel discussion. After that, we go out friends, arm in arm, and a lot of what he says I agree with, but obviously a lot I don't. Little unofficial poll. How many right now, after everything you've read and heard, how many of you think, yeah, I think this PSA screening is probably overdone, and I'm probably not going to recommend it in my practice based on what I've heard so far, just unofficially? Oh my goodness. How many think, yeah, in spite of what you just heard, yeah, I still think it's probably a good idea overall? By far the minority. I would guess about 80-20. Couple of things I disagree with. Slow-growing cancers will kill you just as dead as the fast-growing ones. And I'm also going to ask you, the jury, to disregard everything my illustrious opponent said about breast cancer. It's undoubtedly correct, but it has nothing to do with prostate cancer. I feel like a judge giving instructions to a jury. So my goal is not just to win the debate, it's also to show, among other things, how evidence-based medicine can be used to differentiate what is true, what to believe, what's reliable, what isn't. Just because a study has got a lot of fancy names on it, is published in the New England Journal, and has large numbers, does not mean it's worth the paper it's written on. And I'm going to show you some of the problems with these studies, as well as conflicting evidence, so that you can make up your mind independently. I'm also going to demonstrate on the slides that everything I'm going to tell you is going to be referenced. There will be a source from a peer-reviewed location on everything I'm going to show you, except things that are obviously opinion and, of course, my famous joke slides. Okay, so we're going to be doing this mostly from the attitude of an evidence-based practice and data-driven, and try to hopefully demonstrate that there is very good evidence that opposes what you just heard. So, does PSA testing save lives? That's really the bottom line. Not who's the better debater or who has the better slides, but what is the evidence and how do we make it work for our patients? The new task force report does recommend against PSA-based screening for prostate cancer, including all the high-risk groups like African Americans and those with a positive family history, in spite of the fact that none of the studies you just heard about looked at those groups differently, and they are at substantially greater risk. We strongly and vehemently disagree with those findings. I've actually published on that, and especially when you apply it to a high-risk group, it seems even more risky with patients' lives. Here's what I'm going to try and do in the few minutes allotted to me. Take a look at who the task force is, Who are they? What evidence did they look at? It wasn't just these studies, although that was the predominant factor. What evidence did they not look at or not consider adequately? I'm going to go into detail about the 2 studies because there's a lot of weight on those. Should we believe them or not? If you look at face value, they seem pretty convincing, but when you look in more detail, there's a lot of problems with it. What do the principal investigators of those 2 studies say now that it's been out a while and there's some time for them to reflect and review their statistics and hear the criticisms? I think you'd be interested to know what the principal investigators of those studies are saying. What do other randomized studies and evidence show? What do some of the prostate cancer national experts say? And what about that last study from the VA called the PIVOT study, which seems to show no benefit from treatment, even though that's not the subject officially? Clearly, if the treatment's of no benefit, then the screening is likely to be less important. Some of the statistics, expected prostate cancer deaths in the United States in 2012 estimated to be about 240,000. Prostate cancer deaths in 2012, 28,000. That comes from the American Cancer Society. To me, just looking at those 2 numbers, that's roughly a 12% chance of dying of prostate cancer. African Americans have the highest risk, 50% higher than general population, and twice the mortality rate. So who is this task force? I call them the Gang of 16. An arbitrary government-appointed group of 16 physicians, pediatricians, OB-GYNs, and nurses whose well-meaning but misguided recommendations carry disproportionate weight. There were no oncologists or urologists on the panel. Why is this so important? Because that's why we're all here. It's gotten a lot of attention, and a lot of people are changing their minds. A lot of people think it's the FDA that made this recommendation. It's not. It's a group of 16 people, none of whom have any special practice experience or expertise in prostate cancer. They're just looking at papers. By the way, they were all handpicked by the government, certainly a group we can all count on. Here's a picture of what they look like. You guys are too young. You're not going to know this. But this is Spanky and our gang. All right. The American trial, called the PLCO trial, Dr. Silberstein alluded to this, 76,000 men. They did annual PSA screenings. The complete data, when it was originally published, was for 7 years. There's now 2 additional years and basically shows pretty much the same thing. You need to know it was originally intended to be powered for 13 years. They're not there yet. The 10-year data at the time it was originally published wasn't available, so they extrapolated. You're not supposed to be allowed to do that. The whole point of doing a large study is so that you have real data and you don't get to handpick which center or which parameters you can guess or estimate or extrapolate. They did find no significant difference in prostate cancer-specific mortality. European trial, a bit bigger, but each center in each country did it a little bit differently. A lot of them didn't do yearly screenings. The PSA cutoff was a little different. The original median follow-up was 9 years. It was recently extended to 11. Interesting that after it was published, there was a lot of criticism about the statistics and how they did it. They went back, recooked the numbers, and magically, in a follow-up paper, they came and said, hey, guess what, that 20% number wasn't right. The actual number is 31% survival. Now, this was the same numbers they did before. That's a 50% difference in the conclusion, in the survival advantage. Why didn't they do it right the first time? Do we trust these numbers? So where did that 31% come from? They originally recalculated their data by extrapolating statistics from some of the better centers. So I'm not sure that, even though I like 31% better than 20%, I'm not sure I really want to believe that one either. What are the critical flaws? First one is limited follow-up. We know that for prostate cancer, you need at least 10 years and possibly up to 15 years before you really know what kind of a difference it's going to make with survival. Contamination of the control groups. You already heard that there's significant contamination in the control group in the American study, but it gets worse. They violated protocol by failing to perform prostate biopsies in too many men with elevated PSA levels. So we just concluded 7 to 9 years is really inadequate when you're talking about prostate cancer. Not other cancers, but prostate cancer, due to its natural history, you virtually have no difference in mortality or anything else for at least 5 years. Out to 10, it's also almost identical, although it might start to change a little. You may need to go to 12 or at least 15 years to see much of a benefit. So what about contamination? At least 15% or more just didn't bother to show up. So 15% of your test population is gone. 52% of the men in the unscreened control group had a PSA test during the trial. 44% had one before entering the trial. So here is clearly a very highly selected group before they were allowed to enter the trial on the control group. The number was not reported in the European study. What do you think would be an acceptable percentage of men in the test group? They're getting PSA screenings. You get a number. It's elevated. According to protocol, you're supposed to get a biopsy. What percentage do you think would be allowable and still not affect the validity of the study? How many here think at most maybe 10%? 15%? 5%? Okay, couple for 15, couple for five. How about 20%? You think you can do 20% and still, because there are large numbers, and it still leaves you a lot left. One vote for 20%. Do I have 25%? I feel like an auctioneer. Do I have 25%? 30? How about 70%? How many of you would accept 70% violation of protocol for biopsy as an acceptable statistic? Even if you don't know anything about statistics, you can certainly see that when you have much more than the majority not getting the biopsy that by protocol they're supposed to get, you are violating the essential important statistics that you're supposed to be trying to find. Dr. Pat Walsh from Johns Hopkins put it this way. He's probably the world's leading expert on prostate cancer. Quote, if most of the men with elevated PSAs never underwent a biopsy, how can anyone expect the trial to show that screening saves lives? There are other problems. I won't go into as much detail. Different centers had different cutoff values. They failed to use an age-adjusted PSA cutoff, which might have been more realistic. Time-specific endpoints were used instead of variable ones. They extrapolated results when it was convenient, when the actual data wasn't available, and there was a high contamination and non-attendance rates. There was no specific cutout for higher risk patients, African Americans or those with a personal family history. So those were all lumped in together. None of the statistics looked at that group separately, and yet the recommendation affects them disproportionately. Too many men over age 75 were included. This is an age group where it's generally conceded PSA screening probably has very little benefit because of the long lead time bias necessary to show such a benefit. And the task force greatly overestimated harm from biopsies and radical prostate surgery. They took the absolute worst possible statistics instead of the best, or even something in between. This slide demonstrates from the SEER data the difference between whites and African Americans as far as incidence and mortality from prostate cancer. It's not minor. It is very significant. Okay, what about some of the other evidence? What did they not consider? There's a study done in 1988 by Labrie from Quebec. This is a population study as opposed to the full type of double-blinded randomized. There's some problems with it. But it's 46,000 men. That's a fairly sizable number. They used a 3 nanogram PSA cutoff, which is, okay, acceptable. They had more than 10 years data, which is better than these 2 other studies, showed a 62% prostate cancer-specific survival advantage. That's a lot better than nothing, isn't it? What other evidence do we have? The population winner is the study from Tyrol, Austria. In Tyrol, Austria, they decided to make PSA testing free to all eligible men. They didn't force anyone to get it. It was merely free of charge. You could get it if you wanted it without paying for it. In the rest of Austria, you could still get it also, but you'd have to pay for it out of pocket. So as you might imagine, if you had to pay for it, a much lower number of men decided to get PSA testing. In Tyrol, we had 300,000 plus men who got screened, compared to the rest of Austria, roughly 3.5 million. Now, each group is not pristine. They're not 100% pure, but it does indicate, if nothing else, what free PSA testing can do in an area where the scientific information is the same, the language is the same, the ethnic background is the same, healthcare delivery and hospitalization is the same. Everything is the same except for the fact that if you happen to live in Tyrol, Austria, and were male, you got your PSA level for free. Prostate cancer-specific survival, 54%, and again, much more than 10 years data is included. I think possibly the very best data comes from Göteborg, Sweden. This is part of the European study, but this is the part they don't like to talk about because it is different than what the rest of the study locations showed. Starting in 1994, 20,000 men were picked by computer to either get screened or not screened. So they got screened about every 2 years. Median follow-up was 14 years. That's a good, strong number. Contamination crossover rate was only 3%. How come? Because the Swedes did what they were told. If they were told to be in the control group, they got it, they stayed in the control group. If they were told to get biopsies and PSAs and whatever, they did that. There is no significant flaw that I can see in this study, except it's only 20,000 men. Look at how many studies you look at in the New England Journal and elsewhere where the total population is 100 or 200. Here is a really well-done study. No major problems, no major contamination, no statistical errors, nothing like that. And yet it shows over 50% prostate cancer-specific survival advantage in that population. And Sweden is a country that has a very high rate of prostate cancer mortality. This is an important slide because it illustrates that, at least in this particular screening, starting at 8 years, the control group and the screen group start showing a significant difference in survival, and that difference is widening as you go out further. What else did they not consider? Before PSA testing was started in 1990, 32% of all new cases of prostate cancer were advanced and 21% were already metastatic. Today, that's only 9% with advanced disease, and less than 4% present initially with metastasis. That's a 75% reduction that cannot be explained by anything else. Prostate cancer deaths have fallen 44% in the last 15 years since widespread PSA testing began. This is a greater decline than for any cancer in men or women. Probably not a coincidence. According to the NIH, at least 75% of that difference in survival is due to PSA testing. What's the chance of finding prostate cancer if the PSA is elevated? It's about 33%. How does that compare with other screening tests? A lot better than most. Mammography has at best 25% chance. What other evidence was not considered? The original authors from the European study showed that there was a decrease in metastatic prostate cancer of 42% and a relative reduction in mortality of 38% after 12 years. Now that's getting up near the 50% we mentioned earlier, and chances are if we follow that a few more years, the two curves will widen further. The conclusion of the authors of the study from Europe, Fritz Schroeder, is PSA screening significantly reduces the risk of metastatic prostate cancer and death. Here in 1992, you can see the bump for the detection because PSA testing became widespread. You should be able to look at the green line down below. That's the death rate since 1992 in the US. It shows up better on the next slides. Again, 92, we had a bump in the incidence, but since then, the cancer death rate has been decreasing. And this is data from the government, NCI, and the Center for Health Statistics. Okay, I threw a lot of numbers at you. Still kind of confused, huh? All right, let's see what some of the experts say. Dr. William Catalona is credited with discovering the clinical utility of PSA. He points out that if screening only detected harmless cancers, it wouldn't affect the cancer death rate so much as it has since it started being widely used in 1992. Here's Dr. Pat Walsh again. If the authors had set out to design a study that would discredit PSA testing, it would have been difficult to do a better job. Well, let's look again at what the authors of these two studies. David Crawford from Colorado was a principal investigator on the American study. Fritz Schroeder from Europe did the European study. We should not return to 1989, before the PSA era, when advanced disease dominated. Rather, we should prudently screen men and separate diagnosis from treatment. There's nothing wrong with overdiagnosis, as long as you don't overtreat. He goes on to put it this way. There's a lot of emphasis on primary care who are looking for reasons to stop screening for prostate cancer. Why? There's a lot of confusion about understanding PSA levels and legal action taken against them for failure to diagnose the cancer. That's a real issue here in the US. What about Dr. Schroeder from Europe? What does he say? Their conclusion is different than the task force. They're showing that even after the additional 2 years of follow-up, their previous finding was that PSA screening does reduce mortality from prostate cancer, and their numbers are getting stronger and stronger as more follow-up is done. Still not sure? Has anybody else looked at all the relevant data? Sure. One group is the Canadian Urological Association. They looked at over 1,000 articles and came to the conclusion that screening should be offered to all men aged 50 years of age with at least a 10-year life expectancy. And that's pretty much where many other organizations have come to, including the American Urological Association, the American Society of Clinical Oncology, and American Medical Association. What does the AUA say? Until there's a better test to help us reduce the risk of prostate cancer death, the task force, by disparaging the PSA test, is doing a great disservice to the men who may benefit from it. Well, you're just a urologist, you're too biased. I mean, all you guys want to do is surgery anyway. Got to read the funny slide, a world without bias is too hard, would you settle for world peace? That usually gets a chuckle. Okay. Well, let's look at some opinions from others who've looked at all of this data and come to different opinions. National Cancer Institute, U.S. Center for Disease Control and Prevention, and the American Society of Clinical Oncology. What do they say? Neither the European nor the American study findings are definitive. Shortcomings of these trials provide an unreliable measure of PSA's actual benefit. Their conclusion, healthcare providers must engage in informed decision-making with men to make sure they're aware of the potential benefits, harms, and remaining uncertainties. An excellent review from Sloan Kettering in New York on behalf of the American Society of Clinical Oncology. Task Force report contained a number of important errors of fact, interpretation, and statistics. They overestimated the harm, adverse health effects, and anxiety levels from screening and definitive surgery. The best trials available to date have demonstrated screening can reduce prostate cancer death by 31 to 44%. And all the best doctors say so also. You guys are too old to know Marcus Welby. Hopefully you'll recognize Dr. House. Okay. In summary, a lot of people are disagreeing with these findings. The task force panel was made up of people who had no background in oncology or urology. The recommendations were based primarily on basically a bad review of only 2 published studies, both of which are critically and fatally flawed. And according to independent reviewers, the task force report contained numerous factual errors, statistical mistakes, and misinterpretations of the data. That didn't come from me, although I agree with it. They came from others. So a summary of some of the problems. The follow-up was inadequate. They failed to biopsy 70% of men. Control groups were contaminated. Non-attendance rate of 15%. Unwarranted extrapolation of the data. Included too many men over age 75. No separate evaluation of the high-risk groups. The prospective population studies with over 4 million men from Quebec, Sweden, and Tyrol, Austria, all showed a better than 50% survival. 44% reduction in mortality in the U.S. since PSA testing began, and a 75% decrease in the presence of metastatic disease at initial presentation. So we don't think that there can be much doubt that PSA testing will save lives. But what about that pivot study, the one that was just published in the New England Journal about a week ago, and which was primarily done out of the VA? 731 men with localized prostate cancer who were healthy enough to get surgery were randomized to get either observation or radical prostatectomy. They were followed for a median of 10 years. Their median PSA was 7.8, and their average age was 67, which is a little old. There was no effect on all-cause or prostate cancer-specific mortality from age, race, coexisting conditions, or performance status. That ought to raise a red flag. Does that bother anybody? That if we already know that race has an impact on the mortality. In their study, it didn't show. That coexisting conditions, if patients got heart disease and diabetes and 5,000 other medical problems, didn't seem to make much of a difference. That doesn't make much sense either. Performance status, the people who can't get out of bed because they're short of breath or have heart disease, did just as well as the people who are as healthy as you appear to be. That doesn't make sense either. Something's wrong there. Radical prostatectomy was associated with reduced mortality among men with a PSA greater than 10. We can argue about how significant that was, but their conclusion was it had a benefit, as well as those with intermediate and high-risk tumors. But their final conclusion was that there was no significant difference. The pivot study was done out of 44 VA sites around the country and a few sites from the National Cancer Institute. What are the problems? Well, there's no study that's absolutely perfect. What are the problems with this one? Because you have to look at that before you can decide how much to believe. I know that when I'm looking at a study quickly, I look at the abstract, I take a quick look at the introduction, I kind of switch gears and go to the discussion and the conclusion. Well, you should at least glance at the methods, especially when the conclusion doesn't seem to make sense or is contradicting other information that you may have or what the status quo is. Then you look at every line, every sentence, every word, because every failure, every error, every bias is going to have an impact on the conclusion. So they only enrolled 14% of the people that were eligible. Most of them were from the VA, which may or may not be fully representative of the general population. Only 10% of the patients were younger than 60 years of age, and that's the group that's most likely to benefit from screening. Their overall contamination rate, 20% in each group had crossover. So 20% of the surgery group didn't get surgery, 20% of the non-surgery group ended up getting surgery. Their annual median follow-up was only 10 years, and we know that you probably have to go longer for that to work. It was originally powered for 2,000 participants and for 15 years of follow-up. They couldn't get the 2,000 participants. They settled for 731, and they only had 10 years of follow-up. So they had to go back and recook the statistics to make sure it still worked out and was still valid. And we already saw from the European study how when you go back and start recooking data, it's usually because you didn't like the results you got first time, or there were statistical errors. If you look carefully at the results as they reported it, the surgery group, 21 men died in that group and 31 in the observation group, suggesting a survival advantage of 46% based on my little napkin math, yet the numbers are small, and officially this was not considered statistically significant. But there was a greater than 50% reduction in bone mets in the surgical group versus the observation group. The study was underpowered to identify the intended clinical benefit. When others have looked at some of the data, they've concluded that at least 1,200 men would have been necessary in order to show a significant benefit. The study was underpowered. There was a clear benefit identified in those with PSA scores over 10, but it only appears after 10 years, which is just when they kind of cut it off. By the end of the study, 47% of the surgery group and 49% of the observation group had died. A 67-year-old man today should average an additional 17.2 years of life, according to Social Security Administration statistics, or live until roughly 84 years of age. This group died at 10 years. This was not a healthy group of patients. There's something different about them. Maybe they got exposed to Agent Orange. Maybe they were too old. Maybe they had other comorbidities. Maybe just going to the VA had some effect on their health. But a month or two, or even a year or two, fine. But the difference between 10 years of life expectancy and 17, very few or relatively few died of prostate cancer, that's true. But this group is somehow different, seems to be different than the general population. So be cautious about making general conclusions about it. But what else? What's the alternative? What if we just do nothing? Is there a place that does that? Not quite, but in Sweden, there's a study of 15-year follow-up by Johansson. 223 patients, early-stage prostate cancer, followed for 21 years. That's a long time. No treatment except for hormones if they became symptomatic. So this is just a natural history progression. Most had an indolent course for 10 to 15 years, but after 15 years, now they have a lot of problems. Metastatic disease, bone fractures, pain, bleeding, lots of other problems. Their conclusion was early intervention is warranted in patients with localized early disease who have or might have a 15-year life expectancy. Bottom line, if you believe the PIVOT study and the task force, go live in Sweden. They don't do as many PSA screenings, and they tend not to do definitive therapy. So what are their numbers, since they're following this guideline a little more closely? What are their numbers compared to ours? We have a higher incidence because we're doing more PSA screening, so we're finding more cancers. But the death rate from Sweden is far greater than in the US. Here we have the prostate cancer incidence and the prostate cancer death rate in Sweden, and what's interesting is prostate cancer in Sweden kills more men there than lung cancer. If I'm in Sweden, I ask you what's the number one cause of cancer death in men, it's going to be lung cancer, not it's going to be prostate cancer, not lung cancer. This is something from the World Bank, again showing that the cancer death rate in Sweden is substantially higher than in the US, about 2.5 times. And that's not the worst country, but it's among the worst. These are two studies that were alluded to by Dr. Silberstein. This is pretty much before the PSA era, but the issue here is, does treatment work? And in these two studies, one was 884 patients followed for 10 years, showing a cancer-specific survival advantage between the yellow line at the top and the bottommost line, which was observation, the top line being surgery. On the other slide, you're looking at radical prostatectomy versus other treatments. And again, you're looking at a substantial overall survival. This is from an American study, over 3,000 patients, 65% versus 35% overall survival. What's the bottom line? Bottom line is men are still dying from prostate cancer, and no cancer was ever cured by ignoring it. And if you don't do the PSA screening, that's what you're doing. You're ignoring it. The Pivot article provides no useful information for healthy men in their 40s, 50s, and early 60s, even if they have low-risk disease. What's the bottom line? The real problem is not with the PSA test. I agree with Dr. Silberstein. The problem is it's doing what it's supposed to do. It's supposed to help us find prostate cancers. What we can't do very well is identify which ones are dangerous and which ones aren't. The critical decision about treatment should only be made by the patient, his family, and his physicians, and not preempted by any government-appointed panel of so-called experts. And that's really what this is about. Now you know the rest of the story. We strongly believe PSA testing saves lives. Please help us save the PSA test. Don't be stupid, do PSA testing. And I asked Dr. Silberstein this earlier, does he know his PSA level? And like I said, he's a true believer, he hasn't done it. A wise man makes his own decisions, an ignorant man follows public opinion. Now you know the rest of the story, now you can make up your own mind. Thank you.
So being
Now, if
evidence-based...
everybody's completely confused, Dr. Silverstein is going to make a brief rebuttal. And then I'd like to open it up for questions. We have two experts here. I'd really appreciate your comments, questions, so we can make this as interactive as possible. So.
One of the problems we often see in cancer studies is how you do your graph. If you do your graph by percent reduction, that can be exaggerating. What you want to see is absolute survival advantage. All his studies were percent reduction. Most of them did not have statistical significance, and they were prostate-specific mortality. What you want to know is number of life years saved, absolute life years saved, of death rate, not just death rate from prostate cancer, because some people are going to be harmed from it. So what you want to look for is not the percent reduction, because most men do not die from the prostate cancer. So if we say 50% reduction, well, if only a small percent die, and they're dying at 80, so what you want to look for in studies, and many oncology studies we have that issue, is you want to look at the absolute number of life years saved, not the percent reduction, what you want to do. There are also a variety of different societies have different guidelines. The American Cancer Society has clearly changed their guidelines. There is an editorial by Otis Brawley, the head of American Cancer Society, basically agreeing with most of what the U.S. Task Force says. Those are my comments.
If you want to take the microphone there, you could just have a seat and I'll open it up for questions. Anybody have questions, comments? Yes.
All right, so my question is, the Pivot study was done at VA institutions only. I guess my question is more probably for Dr. Silberstein, but do you feel that the VA is representative of all men? Because I think for those of us who had experience at the VA, and I'm sure yours is much greater than ours, I mean, all you have to do is spend one day there and you know these are not normal or average people. Does it make sense to extrapolate that, especially considering some of these people have like Agent Orange exposure and that greatly increases the risk of prostate cancer?
First, I'm not convinced that Agent Orange greatly increases. But clearly, the veterans population may not be exactly normal. They generally tend to drink more and have more alcohol, so the death rate is more. But actually, if you listen to Dr. Leslie, what he was saying is let's do screening in people at 60 years old and with PSAs over 10. And what he was saying, don't screen people 70, 75. He complained about all the studies in which the people were older. But the VA group does probably have a worse mortality overall. But that again goes, what he's really saying is, rather than screen everybody, screen the younger people, and don't screen the people who have, 10 years to live or something.
If you want to know what Dr. Leslie thinks, just ask Dr. Leslie. I certainly do agree that the evidence seems to suggest that people between 70 and 75 maybe should not be screened, especially if the PSA level is stable. The question is, what about the younger people? The task force recommendation is don't do it at all on anybody, high risk, low risk, above 75, under 75. We don't yet, before we throw the baby out with the bathwater, let's keep the PSA test. Let's look for better ways to identify who's going to benefit the most, where we should put our efforts. A lot of this ignores the fact, and there's currently a study looking at the European data where they're looking at the harm in people who do not get screened and treated, but who get metastatic disease and they're quantitating the bone pain, the fractures, and other morbidity. So in this case, mortality is the easiest thing to measure, but the morbidity from this disease in the last 6 months to a year is much harder to measure. Currently, that's being looked at by the European study group, and they will be publishing that hopefully shortly.
Another comment. In terms of the death rate related to PSA screening, the death rate from PSA screening went down a year after PSA screening. And many experts feel that if you screen, you're not going to help anybody for 10 years. So if the death rate went down a year after screening, it was probably not related to screening and something else. So it is not clear that the death rate that went down coincident with screening is related to screening. Particularly, again, since the death rate went down almost immediately after screening, and screening would be hopefully prevent metastatic disease, which may take 5 or 10 years, you would not expect screening to reduce the mortality immediately.
Was that based on the SEER data? Is that the SEER data that was?
Well, that's SEER data and others.
This, European data too? Okay.
Well, it all depends where you get the data from. It may be that you're identifying metastatic disease that's getting some treatment, and that might help. I don't know the answer, but I do know that it's too premature to ignore that yet. And since I don't know the answer, I'm not willing to ignore the reasoning. But I think that's why the NIH came back and said maybe only 75% of the reduction in death rate is due to the PSA screening and not a different number.
Dr. Silberstein, you mentioned that about 8% of people with prostate cancer will die because of it. And so if about 250,000 people a year are getting prostate cancer, what would your recommendation be for those 20,000 people a year who are going to get prostate cancer? And then Dr. Leslie, if you could talk a little bit about the morbidity and mortality of actually doing prostate surgery, if you could talk about issues of incontinence and impotence.
So the 8% was in the VA population, and that might be a slightly lower because they may be a slightly higher risk population. I think Dr. Leslie said in his group the 12%. The problem is we do not have a good screening test to show when you get your PSA and you get prostate cancer, who's going to die from prostate cancer and who's not. And therefore, we treat 90% of those patients. And until we have a screening test that can tell who has deadly cancer and who doesn't, and also I said inherently, right now our screening picks up the slow-growing cancers. So we have made very little progress in figuring out which people are going to benefit from PS screening and which will not.
There are at least 50 or 60 different markers being looked at to help us do exactly that. And to, again, put our heads in the sand, get rid of the PSA test, and do nothing else while we're in the process of trying to answer the question of how do we predict better who's going to die and who won't is premature. There is clearly, and we do agree on this, there is clearly over-treatment of people with prostate cancer. But I don't think that we should leave it up to the government or a government-appointed group to arbitrarily take that away from us. That's something that every individual has the right to decide for themselves, their family, and their physicians should be making that decision. We should be smarter on doing that. We should maybe let people know that watchful waiting and active surveillance are perfectly acceptable, have lower immediate problems with side effects from therapy, and it's perfectly okay to jump in and go to definitive therapy when it looks like the cancer is beginning to change its characteristics and become dangerous. And certainly 90% treatment rate is way too high. But I don't want the government or any other arbitrary group to tell me who should be screened and who shouldn't. That ought to be based on medical information, and especially when it comes to treatment, that's an individual decision. I don't think any of you would want to have your treatment decisions about a cancer in yourselves, your family, basically taken away from you. That decision is up to the patient and his physician.
I think that's a very important discussion. I think we should talk more about that. So what he's saying is, I don't believe in guidelines. I think the doctors can do whatever they want to do. And I don't want the government, insurance, or everybody else to give the guidelines. And I believe, actually, that evidence-based medicine and guideline medicine and quality of medicine, that you analyze things, that's helpful. I think you have better quality care when you have evidence-based guideline medicine rather than let every doctor decide what he wants to do. But I think that, Bruce, is a very important topic here of whether we want evidence-based guidelines medicine. And there's so many guidelines out there and that have been helpful. And many different organizations obviously have guidelines for cancer screening, from that task force, the American Cancer Society. But guidelines, people are spending lots of time and energy making these guidelines and analyzing it, and every individual doctor just deciding what he wants to do for every individual patient, I think actually gives inferior care.
I have no problem with guidelines that are made based on good evidence-based medicine by people who know what they're doing. I have a problem with guidelines made by arbitrary government-appointed panels with limited experience, no oncologists, no urologists. The data is flawed. The large studies that they took at face value are so badly flawed that they never should have been published or anything else. There are a lot of statistical problems with them. I only pointed out the most blatant. There are a lot more. I think before we have a broadly acceptable guideline, fine. To have an arbitrary guideline based on bad information is harmful and will end up costing people their lives.
This is more for Dr. Leslie, because you want to test people. So if you do test somebody, and I guess at what point or at what level would you want to biopsy and, pursue some, I guess a biopsy is my question, because I think some of us are unclear as once you get the results, I guess we pretty much know that, anything below 4 is normal, but it's like, is it at 4.1? Is it at the 10 mark? When do you start pursuing some of that other further
That's a very good question. I'm going to challenge Dr. Houghton and Dr. Silberstein to see if they can come up with anything in medicine that's more complicated to figure out than this PSA issue. When I finished training in 1982, I thought this was clear, obvious, and if it's over 4, bad. If it's under 4, good. And you may look at some of the change from last year, maybe, and that's about it. Now it's gotten so darn complicated. There's no absolute line in the sand. 4.1 in an 85-year-old is not all that dangerous. 4.1 in a 40-year-old might be, and might be worth following, if not going ahead with a biopsy. It really has gotten very, very complicated. We have a few little tools that'll help. One of them is something called free and total PSA. If the range of the total is between 4 and 10, which is kind of our questionable range, if you do a free percentage, it gives you some statistical guideline as to whether or not that represents a cancer. If it's over 25%, the chance of cancer is relatively low, about 10% or less. If it's below 10, that's a free percentage of 10 or less, that's about a 50-50 shot. So neither group, neither extreme excludes the other, but it gives you some guidance as to what to do. If you're not going to treat the cancer, if that patient is over 70, has got a lot of comorbidities, maybe it's not worth doing the biopsy. That's debatable. That's a different issue than what we were talking about here. It's certainly worthy of discussion, but it is a different issue. If the patient is likely to have a 10-year life expectancy, would likely accept a treatment, then the burden is on you to make sure that a cancer does not escape detection. I can't give you a hard and fast rule about it. I can tell you that the extremes are easy, and this middle ground is really complicated. And in that situation, that's when you probably should use the expertise of a urologist and let us sort it out. This is what we do. And abnormal PSA levels are the #1 referral reason to urology.
But even with low PSA levels, there's a 10-20% risk of prostate cancer, even if you're below 4.
I think one of the issues with telling somebody that their PSA is elevated, and as soon as you mention the word cancer, it's basically the paradigm for patients and what's been taught by for years, I think, American Cancer Society, others, you catch it early, you remove it, you get rid of it. You know, you can tell a patient they have congestive heart failure. Like we saw in the study this morning, you know, a 30% control event rate in the Merit heart failure study for death or hospitalization. You know, you have patients who are going to die of heart failure. That doesn't have the same emotional response that telling somebody they have maybe cancer does. And so that's, I think, explains the 90% of patients who end up getting treatment for elevated PSA or for a positive biopsy. So that it's a different situation in terms of having that discussion with patients and their families. They often opt for more aggressive therapies, and that's one of the complications with this disease. I have a question.
Before you get to your question, I just want to see by a show of hands. We've had the discussion, a bit of a panel, we're almost done. Did anyone change your minds based on what you heard now? Just a few. So most of you are still pretty happy with not doing the PSA testing? Who's still happy with PSA? Who likes it? Okay, just raise your hand if you think, if it's up to you in an appropriate age group, yeah, you think you probably would recommend it. Okay, the other way, how many said, yeah, unless there's a really good reason or a high-risk group, I probably won't? Same people are raising your hands. How many of you are totally confused and don't have a clue at this point?
Hi, I was wondering for some things like Coumadin or for like liver disease, they have a scoring system where you can look at like positive biopsy or family history. You can assign a score to each of those and then get like a score and then figure out if the patient is high risk or low risk based on that. Yeah, like does something like that exist for prostate cancer?
There's nothing quite like that for prediction. There are several nomograms for once you've diagnosed the cancer. You have the Gleason score, which is the pathological or histological appearance. You have the PSA level, and you have a clinical stage. You can predict survival based on age and those characteristics, as well as the presence or likelihood of having positive lymph nodes, et cetera. So those are basically nomograms based on experience from a lot of major centers, and there's a bunch of them. But as far as a PSA level and predicting is it going to be cancer or not, it just turns out to be extremely complex, and we don't have a simple guide for that yet.
You know, to Dr. Leslie, so the thing that, you know, I know at the end you recommend that we should talk to the patients about the options and, you know, give them the two choices. In clinic, it's very hard for a patient when you explain to him that this is a cheap test that won't hurt you. And if you tell him we could screen you for prostate cancer or we could not, and if you show him the evidence that, you know, this evidence says that you can live with it or you can live without it, it's hard for a patient to believe, it's hard to convince him against it. If you're explaining to him the two choices, it's very hard for a patient to say, I'm okay not getting a non-painful, cheap test to, you know, whether it's for curiosity, whether it's for, he never experienced prostate cancer, so he would rather find out. So, you know, we find that if you give them the two choices of whether you should be screened or not, and you give them both datas, most likely they will say, yes, I want to be screened. And then for Dr. Silberstein, the other question I had is...
Let me answer that one first. You bring up two very important points. Usually the answer I get is, wait a minute, I got to go get my wife. They don't want to describe it alone. Number one, the issue about should you do PSA screening, that question. By the time they get to me, that's not usually an issue. But in primary care, it certainly is. I prepared a PSA consent form and fact sheet that has kind of a boiled down little list of facts about prostate cancer, some of the reasons to get screening, some of the reasons not to, some of the key points about how to make a decision, and a place for the patient to indicate, I want the screening, I don't want the screening, I want the doctor to decide for me, which you're going to hear, by the way, and I'm not sure I want to talk about it some more with the doctor. This is just a nice way of knowing who we need to spend time discussing it with and who maybe already has their mind, they already know about it, who've already decided. I don't think most primary care doctors have an extra 20, 30 minutes to go into depth about the pros and cons of PSA screening. It's recommended by more and more groups. I don't see where you guys are going to have the time, on top of taking care of their diabetes, their heart disease, their asthma, and all the other problems you got to do. So this is an attempt to try and make that a little bit easier, but the burden on primary care is only going to increase, and this makes it more complicated. Second question is, how do you convince a patient who has prostate cancer that he's better off without treatment? That's partly something we have control over. If you go to a new car dealer and ask them if you need a new car, what do you think they're going to say? They're going to say, of course, it doesn't matter if you just bought one a week earlier. That's what they do. As professionals, we're supposed to be a little bit more objective and not promote people to get surgery or treatment if they don't need it. But when you're in the prostate cancer treatment business, it's not easy to say it's better off to do nothing. So I put it this way. I would say your cancer is not immediately life-threatening. It doesn't look like it's particularly aggressive or going anywhere. There's a lot of new information saying we may be better off doing nothing. I'd like to watch this and see what happens. We'll do the PSA every 3 months or every 4 months, watch what happens. Because once we start treatment, there's a lot of side effects, and I'd like to spare that for you if we safely can. At the first appearance that it looks like it's going to turn more dangerous, we'll go over the pros and cons of treatment at that point. I don't have a lot of people turn that down. As long as you have a plan, you're going to watch them carefully, and you'll implement treatment when and if they need it, a lot of people would accept it. I think we need to do a better job of promoting a less aggressive approach, and if we do that in part in response to these studies, as flawed as they are, then that's still a good thing.
Dr. Berstein, patients with who has family history of prostate cancer, would you still recommend PSA, and what age and how far relatives do you go?
So again, when you talk about evidence-based medicine, I'm not aware of evidence-based medicine that they've done a study in African Americans who've had previous prostate cancer show that screening improves their survival. Until you see that, you can guess, but it does not mean that screening is going to improve the survival just because they're at higher risk.
That doesn't mean you do away with it. You do the studies, find out, and then you decide what's best. To just arbitrarily get rid of it in your highest risk group because it's convenient is foolish and dangerous. Same information, different views on it.
I had a question about, there was a table in the USPSTF recommendation where they listed the harms and benefits of screening. And this is for Dr. Leslie. I wanted to know which numbers you believed and which you didn't. It was the table about, for screening 1,000 men, how many will have side effects and how many will be saved. For example, they say less than 1 will not die because of the screening. They also say that...
you have to look at... I can't go through it individually like that because you have to look at where the data come from. And it came from basically Medicare data from like the mid-90s, which is about the worst information available. In skilled hands, in large volume centers, your harm from treatment is far, far less than what was in there. I think we don't really know for sure what the exact answer to that, to some of those statistics are. But these are probably skewed too far to the negative. We need to look at some other numbers that are perhaps a little bit more fair.
So where would you place it? Are there any studies that know for 1,000 men screened, how many will be saved?
There are no good studies that I know that give you that exact information. Most of them are not powered to be able to do it or just don't report it. There is some re-review of the European data trying to look at some of that, but their data also isn't all that perfect. This is one of the numbers that tends to be a little misleading because of the again, with your control groups being contaminated and your treatment groups not getting biopsied, the numbers are totally, if you're trying to extract from that, you're taking bad data, doing bad statistics, and coming up with a number you have to defend. I don't think you can.
Okay, so I assume you're also skeptical of the side effect numbers as well. Is that correct? The adverse effects?
I think, to be fair, you have to be, if I'm going to be skeptical about half of it, I got to be skeptical about the other half too. So I do not feel that those numbers are particularly reliable. If you went down the list and tried to find all the worst statistics you could, on prostate cancer treatment and side effects and whatever. If you picked up those would end up in the report. It looks like they made an effort to do that.
And back to evidence-based medicine. I don't think that you can say the benefits and risks of screening are related to the benefits at Johns Hopkins University. If you use the statistics at Johns Hopkins University, that's if you go to Johns Hopkins University. But if you want to know what the benefits and risks are, you have to look at a population-based study. And that's what we have here is a population-based study. Just because Johns Hopkins University can cherry-pick their patients and have excellent care does not mean that's the same level of care that you'll get every place in the United States.
So you like the population-based studies that you like, and you don't like the population-based studies that show 50% or more survival advantage from screening. Interesting.
I guess I don't understand fully the alternative to not screening. So if you don't screen, what happens? Then their patients catch it when they're symptomatic, or, I mean, what did it used to be like before we had the screening?
So the issue in terms of screening is, does screening save lives? If it doesn't save lives, why are we doing it? We are giving many men comorbidities, we're harming many men, and we're not saving their lives. So why are we screening? Just because some people may get cancer, if we don't have an effective therapy. Let me give you another example. I give chemotherapy. Somebody may have failed chemotherapy, and they say, oh, let me give you another chemotherapy. If that other chemotherapy has just as much chance of harm than good, why do you give them chemotherapy if that chemotherapy has just as much risk of harm than good? If screening has just as much risk as help, why do a test that has just as much chance of harming the patient than helping the patient? And that's really what the issue is. Evidence-based medicine, what is the number of men that lives you're saved compared to the side effects? And that's what you should look at evidence-based medicine. How many men are living longer, and what are the side effects, and compare those two.
It sounds like he doesn't believe in secondary chemotherapy. Hearing that from oncologists is really interesting. We clearly need some more and better studies. These were intended to settle the issue. These are large, prospective, randomized, multi-site, followed for a number of years. An enormous amount of money was spent on doing it. It's really a shame that the studies did not perform a little bit better. The few studies that were done that look a bit better have different opinions. That's why it's still controversial. I am hopeful that before we get rid of the PSA and before the insurance companies decide not to cover it anymore, and remember what happened in Tyrol, Austria, when they, if you got it free or had it covered, there was appeared to be a survival advantage. Every country in the world that has a decent healthcare system and generalized PSA screening has a lower death rate from prostate cancer than countries that don't.
My question is for Dr. Silverstein. You've been hammering home here about evidence-based medicine, and you admitted in your talk, though, that when people say, "Oh, you have cancer," or they think they do, they go wild over it. Well, in that, I'm just curious, how can you take the task force seriously when 50% of the control group got a PSA test, as well as the fact that then in the treatment group, over 70% didn't follow the protocol and get the biopsy? I mean, how can you even look at it as evidence-based medicine then?
Well, these are not perfect studies, and the statistics they've done show that they are valid, but they are not perfect studies, and there is contamination, and many of the points he has about the studies are accurate. On the other hand, you need to show other studies that are well controlled, that are randomized, and there are very few of those that show evidence-based medicine, and these are the largest, biggest, best studies we have.
Remember the review we had from Sloan Kettering, where the Society of Clinical Oncologists basically said that the best available data was 38 to 44% survival, cancer-specific survival advantage from screening and treatment. If that's the best available data according to them, I don't see why we should make a conclusion based on bad data. This was supposed to settle the issue. It's too flawed to be able to do it. How much weight you give these studies should determine whether you believe the task force conclusion or not. And even if you believe the studies, believe the principal investigators of the studies. They're not saying to do what the task force says. They're saying the opposite. So the task force, 16 non-urologists, non-oncologists, Would you go for your life and death decision? Would you make that decision based on a panel of gynecologists and pediatricians for something like prostate cancer? I don't think so. If we need to take a better look at it, let's look at other groups that have experience in these areas and have looked at it. And overwhelmingly, they say to continue doing screening, maybe modify it a little bit, do better counseling, maybe try to avoid overtreatment, but they don't say get rid of the PSA test. Very few are actually saying that.
Okay, it's pretty clear that there is a divide in opinions on whether PSA should be done or not. But my question to both of you, and I have a few, so let me finish, please, is who is doing the screening? Is it primary care physicians? And like you said, Dr. Leslie, we don't have time to do the informed consent. We don't have time for a half-an-hour explanation on why the PSA is good or crap. We don't have time to give the patient all the information because the studies are so conflicting that basically we can't offer them anything that would help them, that can make them or help them make that informed decision. And rather than spending time and money arguing about whether the test is good or not, why don't we get rid of it because it's not helping or hurting? We can't tell. Nobody has any idea at all. So maybe time and money should be spent on looking for a new test or some other way to assess the risk for prostate cancer. And comparing populational studies, different countries, I mean, has anyone ever thought of how much variability there is between populations based on environment and exposure to different toxins and diet and habits and exercise? And prostate cancer is something that accumulates over your lifetime, and who gets it is the old men who are 70s, 80s, and have experienced a lifetime of these sorts of insults, which may vary by country to country. So I don't understand how we can stand and argue about 20 different studies. Doesn't matter who did it, doesn't matter who is interpreting it. The reality is there's too much conflicting evidence, and we can't give something to our patients if we don't know what it's going to do for them. Then one thing, can you also address digital rectal exams and the sensitivity of those in detecting prostate cancer that ends up being lethal? I think that's all.
I'll answer the first question. So the who does it is basically primary care. The vast majority of people go to primary care doctors, and as part of their annual physical, they may be offered a PSA or not. Then they may be referred on the urologist, but initial screening, the vast majority is done in primary care.
I wish I could get away with that quick an answer. Yeah, the primary care is going to be doing the screening. You're kind of going to be on the front line of making this determination. I was the first one to point out in this discussion that I don't see how you're going to have time to do an adequate discussion in the majority of your patients. That is going to be an issue. If you believe that PSA testing has the potential to save a life, then you got to find the time to do it or work around it in some way, shape, or form. I provided the PSA fact sheet and consent form to try and minimize the amount of time you have to spend on it. I provided it to Dr. Houghton, and it'll be available to you if you wish to use it, to try and make an inroad in that. But I can't tell you how to do your job in primary care. That's the function of your primary care instructors. If you choose to ignore it, and it turns out to be wrong, and the PSA test would have turned out to save a life, then you'll have to bear that responsibility along with everything else. I think the data is not conflicting. I think bad data and bad studies with bad statistics, improper interpretation of the results, and bad facts and a few other things make these large studies less compelling than otherwise and close to worthless. and I presented some of the data that to me is fairly convincing that it does or can save a life. As far as other countries, if you look, some of them like Japan and China, in that part of the world, they have very low incidence of prostate cancer. We're not absolutely sure why. We know that if we take Asians out of Asia and bring them here to the U.S., where they live in U.S. sunlight, eat U.S. food, and do U.S. jobs, their rate of prostate cancer increases. So part of it may be genetic and part of it may be environmental. But we know far less about that than we do about other aspects of cancer. As far as this being an issue about old men, that's when they end up dying, yes. But I've seen prostate cancer in men in their 40s and 50s, and it is a devastating and aggressive disease in that age group. Less common, certainly. But these people, these younger men die a very miserable death because the disease is a different animal. And I don't ever want to see that if I can possibly prevent it.
I do not think the question is, can PSA save a life? I think the evidence-based medicine is, first, what are the risks and harms? So even if the PSA saves a life, but harms 50 people for every life it saves, and it saves a life at a cost of $2 or $3 million per life saved, is that cost effective? And is the harm worthwhile? So not just can it save a life, but is it, what's the risk versus the harm? And then at what cost to save one life? And the other issue says, well, what would you feel if it turns out the PSA screening turns out to be good? Well, contradiction. What would you feel if the end results in the future turn out PSA screening is bad?
The comment, I think medicine in general, we love new tests. Doctors love new gizmos, and there's an old Monty Python that has an operating room with the machine that goes blip, and doctors love new stuff. And the PSA, I think, if you look, there's an editorial from the discoverer, the inventor of the PSA test, who was concerned about how it became applied to clinical medicine. And things get out there very quickly that maybe have not been studied appropriately, and they're out there and they're being used. And trying to put the cat back in the box is impossible. This has been shown with numerous radiological tests, other things that are out there. We don't really know what their role is or where to fit them in our clinical armamentarium, and yet they're out there, and now we're going back 20, 30 years later trying to figure out if the test is useful or not. I mean, it's just it's just a commentary. Don't expect a response. It's just frustrating.
I'd like to comment. There are all sorts of new screening tests being looked at and things specifically to help us identify which cancers will be dangerous and which ones won't. There's about 50 or 60 of these things being looked at in various parts of the world. We don't yet know the answer. But if someone comes up with the answer tomorrow and you've thrown away the PSA test, how long is it going to take us to catch up again? And how many people will end up dying that might have been saved?
I just have a really quick question. I was just curious if you knew how much a PSA test is individually, and then how much would the subsequent referral and biopsy be to you? For cost.
When I was in private practice, I could answer that, but since I'm with Creighton, I have no input. I believe the actual cost of the test is somewhere around $5, but price to the patient can be anywhere from $7.50 up to $100. But usually insurance covers it if it's just once a year for the screening. But on the basis of this, that may change. I want to point out one other thing. Yeah, well, that's for everybody. If we're talking about the government hiccups, and if we wait about 30 seconds, they'll spend about that much. Well, the question is, what about not just getting the test, but you have to make an appointment with a urologist, you have to be seen, then you have to come back for a biopsy. We don't automatically go into the biopsy quite that easily. We may give 4 to 6 weeks of an antibiotic and see if there's a response so that we don't have to do a biopsy. If we have a nodule or an asymmetry or some other reason that makes us think that it's not worth doing that, we may go ahead. Ultrasounds and biopsies are several $1,000s. That's true. That's just the way the system works. On the average, 1 out of 3 biopsies turns out positive, which is not bad compared to other screening tests, but is much higher than it ought to be. And that's one reason why we do try hard to find a way where we would not have to do a biopsy. Should we pre-screen people to the point where, you know, here's this questionnaire, and if you don't answer the right answers, that means you don't have a 10-year life expectancy, I'm not going to do your PSA test, and too bad. We may be coming to that. But I'm very bad at deciding who's going to live 10 years. I can drop dead tomorrow, I can't be sure. You look at the comorbidities, you look at the statistics. I showed you the Social Security Administration actuarial table for men 67. If you're 67 today, you're expected to live to 84. So in that group, PSA testing and treatment might be reasonable based on life expectancy if you believe that they would live long enough to see the benefit.
I'll tell you something about economics. So in the past, urologists did radical prostatectomies. These days, many urologists go play golf. What they do is they invest in a radiation therapy facility. They buy the radiation therapy facility. They do everybody IMRT, intensive and modified radiation therapy, which is complex radiation therapy. They make $40,000 per patient for radiation therapy. They invest in the radiation therapy facility. They do not do surgery, and they go play golf. And there are many, many urologists who have now owning radiation therapy facilities so they can give radiation therapy to their urology patients and not doing surgery.
Just for the record, I was in private practice for 28 years. I never had a share in an IMRT center. I also stopped doing radical prostatectomies personally about 12 years ago. Why? Because I didn't think the statistical survival advantage over radiation justified it. By the way, for the record, I also don't play golf. Yes, we may refer a patient for radiation therapy. I think it's a travesty that the urologist can invest in such a thing and get paid that much. It used to be we could get paid that much for Lupron treatment, and then eventually the government closed that loophole and you get paid a pittance. And they'll eventually close this one too. That doesn't mean IMRT is bad, or it's necessarily bad if it's owned by some limited partners. But there's too much of an incentive and the money is too good, and that is a loophole, I agree, that ought to be closed or at least made a lot tighter. The actual survival advantage for radical prostatectomy over radiation is fairly limited, primarily in the younger patients with more aggressive disease. Otherwise, it doesn't look like there's enough difference, 5% or less survival advantage between the two modalities.
This question is for both of you. Just in your personal experience of those who've been treated and then have had side effects, what's the patient perspective? Do they, if given the option, would they do it again because they feel that they have peace of mind and they don't know the potential of it being a deadly cancer?
That most people who are treated are happy they get treated. As I say, when people get, let's say back to the women who have breast cancer, I'm saved. So people think that they've had prostate cancer and think, most people think if I didn't have my prostate cancer treated, I'm going to have a 100% chance I'm going to die from prostate cancer. They don't realize they only have an 8 to 10% chance of dying of the prostate cancer. So when they're treated for the prostate cancer, they think they're saved. And if they have a few side effects, so be it. So people have the perception that prostate cancer is going to kill them. And so once they know they have prostate cancer, they think it's going to kill them, and they're willing to take whatever treatment, and if they have side effects, so be it.
That's a 12% risk of dying from prostate cancer. But we could argue over those statistics. It all depends where they come from. But certainly it's a relatively low percentage. As far as how many people does treatment save, I'm not absolutely sure. I feel pretty confident that I can eliminate prostate cancer by treating people with low risk or low grade disease before it's spread. I'm not so sure I can cure people that have more widespread disease. If that's the case, do I want to allow someone with curable disease to progress to an incurable state before I start a therapy? You're taking a chance. Do you really want to do that with someone's life? And should that be up to the patient? To be fair, we need to completely counsel patients about the risks of their treatment, the expectation of a benefit. Look at it this way. I sometimes will explain it like this. I've got a gun here with 100 bullets. 99 are blank. How lucky are you feeling right now? I'm going to give you one shot. All of a sudden, that 1% risk takes on inordinate importance because it's staring you right in the face, and it's life or death. That's how people look at it. So we have to do a better job of calming them down, making sure that there is a plan and a program, and that if and when it looks clear that they will benefit from treatment, that's when we do it.
Example. So Oprah Winfrey, a few years ago, went and had a total body CAT scan. And that was a couple of years ago, everybody was having, including Lincoln. People were giving total body CAT scans to everybody. And you could take $400. And everybody was finding something. And then everybody would get treated for something. It was never shown that doing asymptomatic people, doing a CAT scan, and you're going to find an aneurysm, you're going to find a little cancer, you're going to find all sorts of things. It helped them at all. And the issue is the prevalence of prostate cancer is so high that, and it's not clear that these treatments are helping people. But it is not, there's a great editorial I read that executive physicals are bad. So if you take an executive physical and you get your stress test that you don't need, and you get your CAT scan that you don't need, and you get all these things you don't need, you're going to get harm because you're going to find all these asymptomatic diseases that you didn't know you have, and you get treated, and you're going to have side effects. So screening asymptomatic people, and that's a lot of evidence-based medicine, what asymptomatic diseases is it helpful to find out for? And I'm not convinced that an asymptomatic disease of prostate cancer, which is incredibly prevalent in men, that treating them while they're asymptomatic do them any benefit. But there's lots of other diseases which people have tried to screen for and has not been shown to be a benefit.
I'm just curious, how many of you are going into primary care? Thinking about it. Looks to me like about a third. About right? Guess what? You guys can all leave and go home because, according to him, asymptomatic, unless there's a problem. If there's a problem, they should just go directly to a specialist. A lot of what you're doing, your routine screenings, your yearly H&Ps, all that stuff, worthless if you believe my colleague over here. I don't believe that is true. I do think that you can overtreat, and you have to look at the pros and cons a little bit more carefully. I never heard the word overdiagnosis until I got into this debate here about PSA testing. I don't think there really is such a thing. It's supposed to mean you diagnose a problem that'll never hurt the patient. But it ought to be, but if it's curable or treatable, the pros and cons ought to be up to the patient and not up to some off-site panel deciding what and how we should treat things.
All right. Leaving the personal attacks aside, can we please go back to the question left unanswered? But based on both of your comments just now, we're talking about screening the patients if they're asymptomatic, and two, just blanked, sorry. Okay. The issue of informing your patients that has been brought up several times. As you said, Dr. Leslie, primary care doctors who are doing the majority of this screening at this point do not have time to inform the patients about the nuances of prostate screening, about the PSA test, which is heavily argued and controversial and inconclusive evidence. So basically, and as you said in your own words, you as a physician have to, whatever you feel is necessary for the patient. So, if I feel that the PSA is necessary, then I'll do it. But I'm not basing that on any objective evidence because nothing has proven one way or another, and the medical community has not agreed upon it one way or another. And so you're advising your patient not on objective evidence. And isn't that contradictory to evidence-based medicine in the first place? And the second thing that did not...
I want to stop you there.
Please don't interrupt me.
I'm going to stop you there and answer it while I still remember what the question is. I spent at least 40 minutes going into detail about evidence-based medicine. To me, it's pretty conclusive. I don't know where you've been sitting for the last 40 minutes, but I presented a lot of data from a lot of studies, all of which showed some potential survival benefit. The studies that didn't were badly flawed. You may have a different opinion, and there are different opinions out there, even among us. but I don't think you can say it's still up in the air. There is a lack of consensus on what the final conclusion is based on different outcomes from different studies. There was no problem until the task force published their opinion. Think about it. These studies came out in 2009. There was no big confusion or rush to judgment until this task force came out with their opinion. And that's just 16 people who have no experience in prostate cancer giving you their opinion. Who should we believe? A group of GYNs and pediatricians, or the Society of Clinical Oncology that came out with their review and came to a totally opposite conclusion? I think the data is overwhelmingly in favor of PSA screening saving lives, but I recognize that there is some conflicting data. Show me something in evidence-based medicine that is absolutely 100% clearly positive all the time without a conflict. My area of special interest is in kidney stone disease. Some of you have already experienced that at length, but my point is that there is virtually nothing from an evidence medicine point of view that conclusively shows that doing anything about stones actually works, not even drinking more water. So what is your threshold, and at what point are you convinced enough to make a change? If you still feel that the evidence is not compelling enough to warrant a PSA test, and your patient is not asking for it, then you do what your conscience recommends. Your point about the time is well taken. I pointed it out myself. I think this is a grave problem for people going into primary care. I can't tell you how a primary care doctor should address that time issue. I'm not a primary care provider, and I don't know what to advise you on that. But I've done everything I can to make it easy. I've given you the evidence, I've given you the other opinions, and I've provided a fact sheet to help streamline the interview process with your patient. But I can't do it for you. You're going to have to make the decision yourself. And recognize that while there is a controversy, you're going to have to decide one way or the other. If you do the screening, you're going to take time away from some other problem, but you may save a life. If you don't believe the screening helps, fine, you take a different approach. And 10 or 15 years from now, you may regret it, whichever way you go, because we don't know for sure, and unfortunately, we're not going to know for sure for a while. Do you have another part to your question? I didn't want to cut you off permanently. Just wanted to answer it while I still remembered it.
For screening and can save lives, but much of that data was from other countries. And as you stated yourself, Asians that move over to the U.S. get more prostate cancer. So how can you apply statistics from a population study in another country to people in this country?
Yeah, the question is, how can we compare some of these large studies done in other countries with here in the U.S.? The reason a lot of these are done in other countries has to do, by the way, the American study was done here, and it's worse than almost any of the other studies that were presented as far as contamination and controls and violating protocols, et cetera. It is far more expensive and difficult to do these studies here in the U.S. That's just dollar and cents point of view, it's a lot cheaper to do them elsewhere. And yeah, that is a cause of concern. Same thing as the issue I raised with the PIVOT trial done at the VA. You have a slightly distorted population because their life expectancy was dramatically shorter than what would normally be expected. So you have a point. It would be nice to have an American study done exactly properly, without contamination, without crossover, without pre-screening of the controls, without violation of protocols. If you use that as your basis, of all of the things presented, the only one that does not have a clear and obvious major error is the study from Göteborg, Sweden, and that is one of the smallest of all the ones presented. But no one has showed me a statistical or bias in that study, and until someone does, that seems to be pretty compelling all by itself.
So let me go back again to evidence-based medicine. So I've been an oncologist for a while. Basically, the United States does not do gutsy studies. A gutsy study would be comparing surgery to no surgery, or surgery to radiation therapy. Every time we try a gutsy study, there's bias in the United States, and we cannot get good studies done in terms of very radical studies where somebody gets one treatment and somebody gets nothing. It's very hard to get done. more and more we are having studies done in Europe. The regulatory environment for doing research studies is very difficult in the United States. It's very expensive. The drug companies are going over to Europe or to Poland or to, all sorts of other places because it's cheaper, easier, and better done. So we're having less and less studies done in the United States. If you look at level 1 evidence, and so I'm an oncologist, so they are what we call the NCCN guidelines, which are guidelines for cancer care. Level 1 evidence for lung cancer is 8% of all the guidelines of level 1 evidence. So it's very hard to find good level 1 evidence. Level 1 evidence, is randomized, controlled trials. There are very few of them that really can do it, and it's a problem. Okay, and I actually am a big believer in comparative effectiveness trials, and that's part of this Obamacare, that you're going to have a comparative effectiveness trials. But there's so many of these questions which we do not have good answers for, and there's a resistance in the United States to do the good studies to give us answers. And so a lot of times we're set like here, and we have conflicting data, not great studies, and I do not see another study in the United States being done to look at PSA screening versus not.
So when we're looking at the tests, and even if we do agree that you can save lives with PSA and you're weighing risks and benefits, how do you quantify some of the side comorbidities, the standard of life things? Yeah, but that's the cost of saving a life versus the harms of impotence.
When you look at evidence-based medicine, one of the things you look at is dollars per life year saved. In the old days, they used dialysis. I think it was like, what is it, Bruce, $40,000, $80,000 per life year saved for dialysis? That was sort of the cutoff, and it was felt to be reasonable. When you were going over that, it was felt to be cost ineffective. We also have that in oncology. So in Europe, when you have oncology new drugs, there's something called NICE, it's in England, but it looks at cost effectiveness, okay? And so if it's over, let's say, $100,000 per life year saved, it's felt to be cost ineffective. But they do lots of these analysis, and you can look at different therapies for different diseases, and the number they use is dollars per life year saved, okay? Oregon, several years ago, had a list for all Medicaid, and they said, we'll do these things, and we won't do those things. And they did it by dollars life year saved. Okay? So this trial here shows for dollar life year saved is $5.2 million for one life year saved. If you look at the healthcare system, this is not, it can't be sustainable. I mean, in terms of the amount of money in the healthcare system, if you've saved $5.2 million for life year saved. But you can quantitate, and it's actually a good thing for you guys to do when you look at different studies for different diseases, what is the effectiveness? And that's why I also say you don't want to look at relative reduction. You want to look at absolute years saved, dollars per year's life saved.
I'm not sure where that $5 million thing came from, and frankly, I don't know what the answer is. That might be a good project to look at. But again, if you're looking at the task force report, if you're looking at some of these studies showing minimal benefit, the cost is going to be way up. If you look at some of the studies that showed a benefit that were done perhaps a little bit better, most of them were not done here, so the dollars are not calculated. So I don't know the answer, but I'm not willing to get rid of what seems to be, on the whole, probably beneficial until I know for sure just what all the facts are, what all the pros and cons are, and what the final number's in. But I just eyeballing it, I'm not sure I buy the $5 million per year life saved.
I was just wondering if you guys think there's any, if you know of any efforts or any value into perfecting the treatments and the biopsies and stuff to decrease the side effects, if that might be a acceptable avenue given that the PSA is
Okay,
not
so your
perfect.
question is about the biopsy, because we do a lot more biopsies than we do treatment. Okay, that's a very good point. If you look at this, even if you look at the numbers that Dr. Silberstein pointed out, blood in the semen, hematospermia, is interesting and not dangerous. Hematuria, so I think some 20% had that. It almost always lasts less than a few days. It's not significant. Hospitalization. In my 30-year career, I've had 2 patients who've had significant bleeds and needed to stay in the hospital a few hours. That's out of doing all the biopsies I've done in 30 years. So it's not, although a side effect may be relatively common, it's a very low risk or morbidity, with the exception of the very, very low % that had a problem.
changes that happen is multiple biopsies. And Dr. Leslie knows better than I, but I think it used to be 6 biopsies, now you do 26 biopsies or something. So the urologists are doing many, many biopsies at the same setting. And so their chance of getting prostate cancer is higher because they're doing 26 biopsies at the same time on somebody.
Dr. Silberstein is quite correct. We started out doing 6 biopsies called a sextant biopsy, which means left side and right side, and on each side you do 3, apex, base, and midline towards the periphery. We found that the happy medium, we generally don't do 25 at a time. That's called saturation biopsy, and that's usually where our initial biopsy attempt was negative. Patient is riddled with metastatic disease. He won't treat the patient without a tissue diagnosis, so we got to go back and find it in order to justify their treatment with whatever it is. Usually they're under anesthetic if they get 25. What's the current standard? Current standard is 10 to 12 biopsy samples. So each of those 6 areas that I mentioned, we do 2 samples from each. And that's more or less the standard around the country. And that's quite tolerable because we've learned how to do local anesthetic on the prostate and minimize the discomfort. There is another issue, though, with that, and to be fair, and that is there's growing resistance to the antibiotics we're using, and that might turn out to be a bigger problem. And one of the answers for that is to do a rectal culture and then use the most appropriate antibiotics. But we're not quite there yet. But this is a coming issue, and I hate to give them more ammunition to use against me next time.
I'll tell you another thing about economics. So there's a drug called Provenge. So Provenge is 30,000 times 4, simple math, $120,000. Provenge is approved for metastatic prostate cancer. And what you do is you leukapheresis. So you take out somebody's white cells, then you send those white cells to a factory, and they incubate it with prostate acid phosphatase, and they send it back to you. Fascinating evidence-based medicine. The reanalysis of the trial, the control arm was leukapheresis alone. The experimental arm was leukapheresis plus the incubation. The reanalysis of the data showed that there was harm to the control arm, that leukapheresin, taking out a whole bunch of white cells out of old men, made them die more. So the control arm didn't, so the experimental arm did no good. It just got them back to even because they can back their cells. So for $120,000, you're probably doing no benefit. It got approved by the FDA. It got approved by the FDA because the experimental arm did better than the control arm. But reanalysis shows the control arm was harmed. So if the control arm is harmed and the experimental arm just gets you back to baseline, it's no good. That's $120,000 per treatment for men, and it's probably ineffective treatment.
Allow me to point out that Provenge is given by the oncologist.
Hi again. If it's okay with the panelists, I'd be interested in hearing Dr. Houghton's thoughts on the methodology and analysis of the studies in question, since there seems to be a tie up on the stage.
My job is not as tiebreaker for this. That's why we have the panel. The concern, I think, was pointed out, the difficulty with getting agreement about controversial topics and studies. As I mentioned before the panel discussion, when you're looking at make guideline decisions, you try to use randomized controlled trials as the highest level of evidence to base decisions for screening. Look at them the same way. Look at those questions the same way you look at a therapeutic decision making. And the best studies we have are the ones that the panelists reviewed, and there are obviously flaws. There's no perfect study. One of the things I want you to go home with is understanding when you first start doing this, looking at studies and critically appraising articles, you're going to find out very quickly there is no perfect study. There's always some problem. There's issues with, as mentioned, cross-contamination or intention to treat issues, or how do you, or issues with some methodologic changes. There's no perfect study. You can always find flaws in studies, but your job as a doctor is to understand what's the best level of evidence that we have and use that to make your therapeutic decisions. So I don't have a right answer. The purpose of the panel is for you to decide and make your own decisions.
One of the issues here about the studies, which ones are good and whatever, I had the burden of basically trying to destroy two very large studies. And when you are reading other studies, you're going to need to employ the same techniques in order to decide which ones are good, which ones to believe, which ones have a good outcome and it's probably reproducible and believable, and which ones don't. So even if you don't agree with my conclusion, I hope you recognized what we did in order to evaluate the study and try to provide some context as far as believable, not believable, highly credible or not. The task force did exactly that. They just came to the wrong conclusion. They voted these two studies fair and good. Everybody else who's looked at it, every other organization and panel that have looked at these studies have determined they are not nearly as important or as significant in their conclusions as the task force gave them. And that's there's about a half a dozen other groups that have looked at the same data and all of them came to different conclusions, not giving as much weight to the studies.
So I think, yeah, and I think that
I'm not surprised.
I think that these are interesting points. I mean, who has the burden of proof here? I would argue that if you're trying to create a screening test for everybody, I would argue that the people promoting for the PSA has the burden of proof to show greater, benefit than harm if you're applying it to everybody.
I think, just to generalize also, guidelines, surprisingly, we have conflicting guidelines. There actually are several that agree with that. But overall, when you look at guidelines for other things, you may have several organizations that give the same guidelines, but they're conflicting. So when you're trying to say, what guidelines do I follow, there may be conflicting guidelines depending upon, for a variety of different things, there are conflicting guidelines.
I mentioned earlier about the colon cancer screening. CT colonoscopy was rejected by the U.S. Preventive Task Force as having insufficient evidence for screening for colon cancer, yet the American College of Radiology, American College of Gastroenterology recommend using CT colonoscopy as a screening modality for colon cancer. This is something that happens across the board, and it's going to be part of your lives, figuring out which guidelines to believe and which guidelines to be skeptical about. And I think with the U.S. Preventative Task Force, coming back to what I discussed before the panel, the purpose of the task force is to take healthy patients across the board, healthy patients who are going about their lives, not having any problems. You're going to pull them off the street and put them through some type of a test. You're not talking about doing a test for somebody who's having back pain or somebody who's having urologic symptoms. You're talking about people who are going about their lives, taking them and bringing them in to do a specific test. So this accounts for not only just prostate cancer, but colon cancer, breast cancer, screening for talking to them about suicide risk, talking to patients about drug and alcohol abuse. All those things are under the purview of the U.S. Task Force. You're talking about doing something to a patient who's otherwise healthy. And so I agree with the last comment. I think you have to have a pretty strong reason for doing something to a patient. The first thing you learn in medical school or have heard of is do no harm. So I think there are very good reasons we have differing opinions about the guidelines. One thing I've noticed in medicine is that the more controversy and sometimes the more divisive the evidence is, the more vehement sometimes the arguments get from one group to another. Looking at albumin versus saline for treatment in sepsis. I mean, you have strong proponents one side, strong proponents the other side. When you actually look at the studies, there probably isn't a lot of difference. This is what medicine is like. It's not always black and white. There's a lot of gray out there. Maybe I'll ask the panel to just, summarize things briefly, and then we can wrap it up. One quick thing, make sure you sign in if you did not sign in for the afternoon, so you get credit for being here. And then please turn in all your goldenrod sheets as well to Pat Blue. At the beginning, I'll ask the panel to leave maybe just a few comments at the end, and then we can wrap it up.
Okay, I want to answer a couple of questions that were asked earlier that we never got around to. One is your point about what's the burden of proof to do PSA in the first place. This was addressed in the 80s and early 90s, so there was a burden of proof hurdle in order to get it approved. I don't have time to go into it, but suffice it to say it had to meet the same requirements for a screen that any other screening test would have. It's only now, because of the long lead time, that we have this abundance of data which is, I'm sure, a lot more confusing than clarifying. Someone asked earlier about how do you identify prostate cancer if you're not doing the PSA test. One way would be with a rectal exam, but that's relatively infrequent. Another way would be when you do prostate surgery for other reasons, and you look at the tissue and say, oh my gosh, there's prostate cancer there, so it's incidental. And the other one would be diffuse metastatic disease and complications or fractures or problems with that, and then you end up with a much more difficult situation. I'm going to tell you something else about PSA testing that is not evidence-based medicine, and that is my practice prior to 1992. And PSA testing becoming widespread. I saw at least one metastatic advanced disease patient a month, sometimes more, as initial presentation of prostate cancer. These are people that I knew from day one I wasn't going to cure. And to look someone in the eye who's maybe 55 and tell him he has maybe 5 years left and that I'll help him along the way, but I cannot cure his cancer because we didn't have a way of discovering it earlier and it's already metastatic. That is just heartbreaking. It just tears me up. So I did not go into urology so that I would not be able to help people. I went in so I want to cure that person. So yes, that personal experience does affect where I am today. And the last thing I want to do is go back to the days when we had multiple people a month coming in with metastatic disease that was incurable, knowing that they were facing not only a life-limiting disease, but one that was going to be particularly devastating in side effects, pain, and fractures and other problems. I think there's the abundance of the information. If you weigh the pros and cons, how much weight to give all of the evidence, I think it comes down pretty strongly in favor. And until it's clear that it doesn't help, I'm not sure we're quite ready to throw it all away, go back to the 19th century and do nothing. We have a cancer that is killing 30,000 men a year. We have what we think are potentially curative therapies. Let's not throw it away until or unless we should make it better. But until then, let's continue the research on better treatment and not eliminate what is probably a beneficial screening test.
So let's talk about evidence-based medicine. So I'm a believer that evidence-based medicine helps, and I'm a believer that if you follow guidelines, you have less mistakes, less error, and you treat your patients better. Though actually to figure out which guideline to use is not so easy and actually takes some analysis. In this situation, there's conflicting information between the different guideline committees, which would make your life very difficult when they don't all agree. When you look at studies for advantage, you should look at absolute years life saved. You also should analyze the risks. So you have to compare the absolute years life saved compared to the absolute years life lost or the harm. You actually, when you're doing studies, you also look at cost effectiveness. In this case, 5.2 million. But there are studies out there that tell you how cost effective a different treatment is. It is a serious issue, hard to do, but I think that evidence-based medicine, comparative effectiveness research is the way to go, and there are lots of problems with that in the United States.
To thank both our panelists.